Hey, it's Ralph. Yes, the good old Wreck-It Ralph. I got a little bit of temper on me and always express my anger by racking things up. Hey, you moved my stump. Anywho, I'm a wrecker and I wreck things professionally. Since I'm playing the bad guy role, no one else seemed to like me for doing this. I'm a good guy, but technically speaking, I'm a bad guy too. I often feel abandoned, empty, and completely useless. That actually made me impulsive and indulge myself in dangerous activities like this, where I entered hero's duty and caused a catastrophe. But this is when I found my faithful companion, best friend, and my favorite person, Vanellope. She fulfilled my emptiness and made me feel like a good guy again. Although I have made frantic efforts to keep her close to me all the time, the fear of getting abandoned by her really haunts me. So, do you feel just like Ralph right now? Then, you might show signs of BPD.
Today, we will be shedding the light on BPD, which is borderline personality disorder. P.S. This is an awareness video to educate people on BPD. Do not use it for self-diagnose, and if you may find having the symptoms stated, please seek help from a professional. BPD is a complex mental health disorder in which the patients will have an intense fear of abandonment or instability, and they may have difficulty tolerating being alone. It is harder for them to return to a stable baseline after an emotionally triggering event. BPD is often accompanied by depression and anxiety, as well as addiction problems in some cases. In Malaysia, BPD is estimated to be occurring in 6% in the general population and up to 20% in the psychiatry inpatient population, 10% in psychiatric outpatients, and 5.4 individuals do not seek psychiatric help.
With that being said, here are the signs and symptoms of a person with BPD. Number 1. Fear of real or imagined abandonment by loved ones, in which they make frantic efforts to keep the other person close by clinging onto them and tracking their movements. At some point, this feeling of extreme love and idealization may change drastically to extreme dislike, anger, and devaluation, leading to the second symptom, which is a pattern of intense and unstable relationships with family, friends, and loved ones. They may also have a distorted and unstable self-image or sense of self, extreme mood swings, uncontrolled anger, chronic feeling of emptiness, self-harming behavior, and often indulge themselves in impulsive and dangerous behaviors like spending sprees, reckless driving, and binge eating.
While the exact cause and pathophysiology of BPD is not yet fully understood, it is likely a combination of genetic predisposition combined with early childhood environmental factors and neurobiological dysfunction. To date, no genome-wide significant association was found for any single marker for BPD. However, a positive family history, especially first-degree relatives of psychiatric illness, have high risk for BPD. Gene-based analysis yielded two significant genes, DPYD on chromosome 1 and PKP4 on chromosome 2. Interestingly, a study also found significant genetic overlap with bipolar disorder, major depressive disorder, and schizophrenia. Next, history of physical, sexual, or emotional abuse, maladaptive parenting such as maternal hitting, punishment, and hostility. Problematic peer interactions and bully victimization are also more likely to represent a central process development of BPD. Moreover, in BPD, smaller gray matter volume in the brain has been observed. At the same time, it is also linked to a smaller volume of insula and amygdala, with an overactivity of these regions in emotional processes. Next, Serotonin dysregulation may also reduce the sensitivity of receptors, which could contribute to BPD. Lastly, alterations of neuropeptide oxytocin system also involved in the pathophysiology of BPD due to its role in the regulation of social reward.
So, how do we treat BPD? Till this date, the first-line treatment is non-pharmacological treatment. That is, psychotherapy, also known as talk therapy. This treatment has shown large reductions in symptoms and have been developed over the past 20 years to specially treat BPD. The most popular and oldest specialized treatments under psychotherapy are the dialectical behavioral therapy (DBT) and mentalization-based treatment. DBT is a modified type of cognitive behavioral therapy, and it is the very first treatment developed to shown to be effective for BPD. It uses concept of mindfulness or awareness of one's present situation and emotional state. Settings in which DBT is often conducted includes group therapy, where patients are taught behavioral skills in a group setting; individual therapy with a trained professional, where a patient's learned behavioral skills are adapted to their personal life challenges; and finally, phone coaching, in which patients can call the therapist between sessions to receive guidance on coping with a difficult situation they are currently in. Next treatment is MBT. The goal of this treatment is to improve the patient's ability to mentalize, that is, to understand his or her own and others' mental states. This treatment uses weekly individual therapy sessions and group sessions over 18 months. It has the advantage of having much shorter training periods and requirements than the other treatments. Other forms of psychotherapy may include transference-focused psychotherapy and systems training for emotional predictability and problem-solving, known as STEPS. Transference-focused psychotherapy is a variant of psychodynamic psychotherapy. This therapy mainly focuses on emotions arising in the relationship with the therapist and the therapist's use of traditional psychodynamic techniques such as interpretation. Meanwhile, STEPS is a 20-week group therapy program for patients with borderline personality disorder that incorporates the elements of cognitive behavioral therapy, skills training, and systems therapy. Meanwhile, we also have pharmacological agents to treat BPD. However, the role of pharmacological treatments in treating BPD is very limited. First of all, this is due to the limited data available on the efficacy of drug in treating BPD patients. Next is due to the short interval clinical trials that are very much less applicable in actual clinical settings. And lastly, there isn't any single drug that cures BPD. Hence, physicians always select a medication based on the risk to benefit ratio. Patients are only hospitalized in extreme situations like self-injuring and attempting suicide. Pharmacological management may include prescription of anticonvulsants, antidepressants, and antipsychotics. These medications are often aimed to alleviate emotional symptoms. Anticonvulsants are often used as mood stabilizers. For instance, valproate is used to improve symptoms like irritability, depression, and social functioning. Meanwhile, lamotrigine is used to control anger. Next, antidepressants are also used in BPD to relieve symptoms like depression, anxiety, and emotional reactivity. Examples may include fluvoxamine, which improves BPD symptoms except for anger, and phenelzine that improves only hostility and not other BPD symptoms. Finally, antipsychotics are also used to reduce impulsive behavior, anger, anxiety, and similar emotions that result from BPD. Examples may include haloperidol, which significantly improves general functioning but worsens the depression symptoms, and aripiprazole that may improve anger, hostility, depression, anxiety, and interpersonal and social functioning. Trying one medication at a time is always suggested in pharmacological treatments, even in the context of partial response, because there is no evidence to support polypharmacy in treating BPD patients. So, moving on, can we really prevent borderline personality disorder? The sad truth is, there is really no way to prevent borderline personality disorder. This is because BPD is often inherited and passed through families and triggered by traumatic events. Hence, you may have an increased risk of getting BPD if you have a family history of BPD. The solution is to seek help from medical professionals if you notice any early signs of BPD.
To conclude, BPD is no doubt still largely underdiagnosed, undertreated, and stigmatized. This can be attributed to reasons such as controversies surrounding the diagnosis and concern that patients may get stigmatized. Oops! Wait! Before this video ends, let us debunk some myths regarding BPD. The first myth is people with BPD cannot lead their own independent, fulfilling lives. Debunk. Well, actually, once a person has received effective treatment, they are often able to be independent and live the lives they want to. Second myth is those with BPD do not commit suicide. They are just attention seeking. No, BPD is associated with higher rates of suicide and self-harming behaviors. Lastly, there is also a myth saying you cannot treat BPD. With the help of medication, counseling, patient's own strength, the support of family and friends, the symptoms of BPD can be reduced. It is not easy to treat BPD, but it definitely can be treated. With this video, we hope that the life of a BPD patient can become more meaningful after being understood by the public and being helped with the right proactive treatment approach from the healthcare team. All these efforts would help shorten and alleviate the hidden suffering in people with BPD.